everyone, my name is Dr. Patrice Baptiste, and I'm so excited to be speaking to you all as part of the International Shadowing Project. I'm very honoured to have been invited to speak to the students at Duke Kunshan University. If you do have any questions after the talk, then please email the students who have organised this talk as part of the project, and I will do my very best to answer those as much as I can. So let's start the talk. Okay, so like I said, this talk is going to detail some of my experience as a GP in the UK, and I will incorporate a clinical case and some information about the National Health Service here in the UK. So as always, I'd like to start by explaining to you guys that I'm on a number of different social media channels, and I like to connect with students like yourselves so that I can help you guys and support you on your medical career journey. If you don't know already, I have a YouTube channel, so feel free to have a look at some of the content that I have. I also have a membership club, which is not limited to students in the UK. And in that membership club, I go through a number of different topics to support you on your medical career journey through medical school and hopefully beyond in the future. So I will be hosting live streams once a month in which we will go through different topics. And I'm hoping that through the membership club, students like yourself will get to know me a bit more. I'm also on LinkedIn, Instagram, and Twitter, so feel free to connect with me there. And I do have a website if you want to know a bit more about the work that I do. So let's talk about my experience. So why did I choose medicine? Well, for a number of different reasons, really. For me, I always felt that medicine was a vocation. I always felt that it was a calling. In addition to lifelong learning, I wanted to help people, which is what we all say, isn't it? But it's very true. And so those were some of my reasons as to why I chose medicine. I felt that medicine suited my personality, the type of person that I was and that I am. So I studied at UCL, University College London Medical School, and I graduated during the year 2013. I left UCL with also a medical degree, but also a BSc in speech science and communication. So if you're not familiar, at some universities it's compulsory, but there usually is an opportunity to undertake a year-long degree in between 2 years, 2 or 3, or at upper points in the medical degree program. I have a BSc in speech science communication, and of course my medical degree. Then I started working as a doctor. So here in the UK, you complete your degree, which standard, the average duration is 5 years of the medical degree, but I did 6 because I did a BSc, and it can be 7 if you've done a degree beforehand. So you do your medical degree and then you start working in the NHS, the National Health Service. You have to complete 2 years compulsory training as an FY1, a foundation year 1, and then a foundation year 2. And when you start working, you have a provisional license, and then you have a full license or full registration with the General Medical Council or GMC. So when you leave medical school, you're a doctor, and then you have to complete those 2 years. I do talk much more about the training pathway and what happens after years 1 and 2 in some videos on my channel. So be sure to check those videos out if you want to know a bit more about that. So after F1 and F2, I took a year out of training, which is not uncommon now. More and more are taking time out of training to just take a break, to maybe get some more experience in other specialties. Because you do have to choose a specialty quite early here in the UK. After F2, you then can decide what you want to do and what training program you want to apply to. Some people don't feel ready for that, and taking a year out to get some more experience and to just enjoy a bit of life and not working, full time or working quite a lot, which can happen during the foundation years. F3 or F4, if you take 2 years out, it's a very good time to do that. So that's why I did. I just took 1 year out, and then I applied to the general practice or GP training program. Now, there were a few reasons as to why I chose general practice, which I do talk in great detail about on my YouTube channel. But for me, one of the reasons I chose medicine was because I wanted that career autonomy. And I felt that actually working in the hospital, it may be a bit more difficult to do that versus being a general practitioner. So I felt I would have much more control over my career, much more control over my working week and my work-life balance. And in addition to that, I really felt that I could be the doctor I had envisioned when I was 4 years old, something that I felt would be very difficult for me to achieve if I was working in the hospital. there are pressures in whatever you decide to do. And it's about managing those pressures and about deciding if you can tolerate those pressures and you can adapt to them, and if certain specialties and career paths suit your personality. And for me, I felt that I could achieve many things by being a GP. So for me, those are some of the reasons as to what makes GP unique. I'm not sure I would say unique, but those are some of the things that make general practice or made general practice stand out to me when I chose to become a GP. So I applied to GP training. Now, GP training is a run-through training program, which means that you don't need to complete kind of pre-training or training before you apply to this program, which you have to do if you want to apply to other specialties. Again, I do talk about this on my YouTube channel in much more detail. But essentially, I could go from being a junior doctor as an F1 or F2, sorry, finishing my foundation training to just applying straight away to the GP training program. So that's 3 years. There are different lengths based on the type of program and what you want to do, whether that's academia, for instance. But I chose a standard 3-year training program. And then I became a GP, of course. In terms of challenges that I face in medicine in general, I would say probably just the workload. There is quite a lot to do, whatever you embark on, and it's about juggling that. And also, what I would say is the constant learning. I mean, that's one of the reasons I chose medicine, but in practice, it can be quite difficult sometimes to stay up to date with everything that's going on. So I would say those are some of the challenges. I think also trying to speak to different and relate to different types of people. You see so many different people from different walks of life, and it's about trying to be able to communicate clearly with them and tailor the management plans to them and their needs. And I think that also can be a challenge sometimes, in trying to do the best for the patient and try and make them happy where you can, because sometimes it's not possible to make people happy. So there are some challenges in that respect. In terms of general practice, again, I would probably say much of the same in terms of the amount of patients that you have to see and the workload at times. But otherwise, I think I would definitely recommend you choosing general practice. I think now that we're in the pandemic, remote working has presented its own challenges, because where you would see the patient face to face and being able to examine them, you're not able to do that if you're speaking to them via phone. But there is so much you can still do when you speak to them over the phone or via another medium such as video consultation. What I would say, which I will talk about a little bit later, is that I do more telephone consultations on emails than I would do video. I think if a patient needs if you need a bit more, I probably would bring the patient in face to face versus doing a video consultation, because I just feel you can get so much more from bringing the patient in to the surgery in person than you can do over a video consultation. Because say, for instance, it's a rash, even over the video, it may still be difficult to see that rash. Yes, patients can also send photos, which is very good. But I think if I'm limited via the phone or email, I would then ask the patient to come in if it's obviously, of course, safe to do so. So I qualified as a GP, and then I started working in GP surgery. Given the pandemic, I've now left my role as what we call a salary GP. So I was employed by the practice to become more self-employed now as a remote GP. So I just work completely remotely. So let's talk a bit about the NHS, or National Health Service. So it's a publicly funded healthcare system. So as taxpayers, we essentially pay for the healthcare system. It was launched on July the 5th, 1948. And there are 3 core principles that I think are very important to share with you right now. The first one is that it meets everyone's needs. The second one is that it should be free at the point of delivery. And the third one is that it's based on clinical need. So this is a brief slide about the NHS. I'm not going to go into too much detail here. I have spoken a bit about the training pathways. But if you do want to know more information about them, then please feel free to send me an email, or there is much information that you can find again on my channel, but also via on the internet. If you even Google the NHS, they have a website which I'm sure you can find much information about the history of the NHS. A bit more about how it's set up. So there is primary, secondary, and tertiary care. Primary care, that's what I'm working. And so this is essentially like the first port of call or the first point of contact, I would say usually, unless there's something a bit more acute and the patient should go to A&E. General practitioners do deal with acute illnesses as well, but if it's something that cannot be managed in primary care, because we don't have blood tests or x-rays easily at hand, then the patient might need to go and be seen in the hospital. So as a GP, a generalist, general practitioner, we are in primary care. Dentists and pharmacists are also classified as working in primary care. So it's more of an umbrella term. Then you also have secondary care, where you have more specialists and generalists. GPs do work in the hospital actually, but to keep it simple, you know, that's where you go to see a specialist. And then in the hospital, you will see, sorry, the S is missing from the surgeries. Planned, so planned care like surgeries, operations, clinics. And then, of course, you'll have A&E, accident and emergency, and out of hours care. I have a video on out of hours care, so I'm not going to talk about that here. But if you do want to know what out of hours care is, what that is comprised of, then please check that video out. And then tertiary care is where it's very highly specialized care, for example, cardiac surgery. Now, why would you refer? So there are many reasons as to why you would refer. Again, if there's something that you cannot do in primary care, then the patient does need to see a specialist. If there's a condition that is not adequately or able to be managed in primary care. So for instance, if someone has acne and you have tried several treatments and it's not helping the patient, then you should refer that patient to see a dermatologist, a skin doctor, skincare doctor. There are many other reasons, of course, but that's just one of them. And in terms of MDT working, multidisciplinary team working, that's where many different healthcare professionals will work together for the best interest of the patients. Patients, especially who have multiple comorbidities, multiple medical conditions, cannot be managed just by one healthcare professional. You will need, in most cases, a GP. So let's give an example here. So for instance, if someone has heart failure, they will definitely be managed in secondary care, because they will need to see a cardiologist. Of course, there are different levels to this, but let's just say this patient has heart failure that needs to be treated by a specialist because of medical management and so on and so forth. So they will be seen by a specialist in the hospital. They'll be seen maybe every 3 months or so on and so forth. But also they will need to be managed in primary care. When they're not seeing the specialist, they will need to be managed. The medications may need to be adjusted. They need to check their blood pressure, their heart rate, leg swelling, so on and so forth, their symptoms. Are they short of breath? Are they more short of breath than usual? And so the GP will need to manage them when they're in the community. You may need to seek the advice of a pharmacist in terms of the medications that they're on. Are there medications that interact with each other? Are there medications that can't be started because it's not suitable for the patient? Are there contraindications, reasons as to why that patient can't have that particular medication? The patient may need support at home. They may need help with managing the stairs, washing and dressing. And so you may need to seek the help of OTs, occupational therapists, physiotherapists to help with maybe some mobility issues that they may have. So working in the MDT is very important, especially for patients who have multiple medical conditions or who have a very complicated medical condition that is just not possible to manage on your own as a GP, for example. So I was asked to speak about a typical day in the life of a GP. I have a few videos actually about a day in the life. There's a day in the life of a GP and a week in the life of a GP, which both have clinical information. So I would urge you to watch those videos because they do have a lot of information in them. Very briefly, I will talk about what I used to do and what I do now. So like I said at the start, very briefly, I was employed by a GP surgery. So I was an employee, and that's what we call like a salaried GP. I did a number of sessions a week. So I did 5 sessions, and one session is usually about 4 hours, and you do usually a morning and an afternoon clinic, or you might have a half day. So you do a morning clinic. And so I would do 5 sessions spread over 2.5 days. Now I work as a locum. And so my work isn't necessarily in sessions, it's more in hours, I would say. But you definitely can work in sessions as a locum. It just depends on where you're working and what you choose to do. So I was employed, now I'm self-employed. And when I was a salary GP in the pandemic, during the pandemic, when it started, it was or still even now, so it's partially remote working. So you would, or telemedicine, so you would use a combination of face-to-face, telephone, video, and so on and so forth. But now I work fully remotely, so I don't see any face-to-face patients. If a patient does need to be seen face-to-face, I will direct them to their surgery, so a GP on site can see them. But what I do now is, like I said, just emails, telephones, consultations, occasionally SMS or text messaging, but most of my correspondence can be done by email. And you can actually write so much more than a text message, or the service that allows us to send messages. There's a character or word limit. So email is actually much better anyway. And like I said, so usually we'll work in sessions or have clinics, but mine is more kind of, I see a set number of patients, and I choose how many patients I will see in a day. So that's a day in the life in a nutshell. I have 2 videos that are really good and beneficial for you to see. I'm not going to spend more time talking on that. If we talk now about the impact of COVID, yes, when the pandemic started, it just wasn't feasible. It's not safe to see patients face to face. So you can, limit the spread of COVID. Before the pandemic, you would see patients, of course, face to face. And you would obviously do some telephone consultations as well, but it would be a very small amount. But now there's more of a combination, still heavily on remote working. But as things progress, you'll probably see that might reverse slightly, and definitely more of a hybrid model where remote consultations are not going to go away, but more of a combination, really, where you will use those to work in sync or in harmony, and to also what suits the patient. Some patients have busy lifestyles, and actually all their carers and for loved ones, and so a remote consultation like a telephone is much better for them. If they have mobility issues and can't get to the surgery, then telephone consultation or email is going to be better for them. In terms of treating patients with COVID, yes, that's another impact of COVID. It's a novel, new condition that everyone had to learn about. And so that also presented some challenges, the symptoms, and then there were new and emerging symptoms or something else that you had to think about. And then also complications. So there are patients who have had COVID, they've got through the acute illness, and then they're left with things like fatigue, memory impairments. And there are clinics now set up to help manage patients who are presenting with these symptoms. Another impact of COVID is, of course, the vaccine. Knowing about the vaccine, the different types of vaccines, and implementing the vaccine program here in the UK, GPs have helped implement that program, have helped to deliver that program, and educating patients. There are patients who don't know much about the vaccine. There are patients who are frightened to take the vaccine. There are patients who have concerns about how the vaccine can impact them, their medical conditions, their future health. And so it's about trying to educate patients about that. It's also about trying to manage complications and be aware of what could potentially go wrong after they've had the vaccine. After the vaccine, like with many other vaccines, you might feel slightly unwell, which is normal. However, in some cases that we've seen, in very small proportion of patients, there have been complications like blood clots. So there have been quite a few things with COVID that, as health professionals, we've had to learn about and have to navigate and have to manage. So that's what I would say about some of the impact of COVID on working as a healthcare professional. So let's briefly talk about a typical case that you can see in general practice. I do have what I've called 5 in 5 videos, which are more clinical based videos on my channel. I generally don't talk about clinical stuff, clinical information, until like recently, a few months back, I started a series called 5 in 5. So that's where I have 5 plus, usually it's more than 5 clinical tips in 5 minutes, and usually it's not 5 minutes, it's actually under 5 minutes, but I thought that was a catchy name. So if you want to know a bit more about clinical information, like how to take a history, tools that help me as a GP, then check those videos out. I do talk about some cases, clinical cases in those videos. So let's get into a case that I've prepared. We have a 47-year-old female that's come to me in the GP surgery. She says that she has had 3 days of burning and stinging when she passes urine. She's also had to go to the toilet several times throughout the day, which is not usual for her. And she has had some tummy pain, which has not been there all the time, but it has been quite severe. And she's rated that on a scale of 7 out of 10. Other than that, she's generally fit and well, doesn't have any medical conditions, doesn't smoke, doesn't drink alcohol. She lives with her husband and has 1 child, and she works as an accountant. And like I said, otherwise, she's generally fit and well. So what are we thinking could be the diagnosis? So there's a few things you want to think about. I think at the top of my list is a UTI, a urinary tract infection, uncomplicated, can be managed quite easily. Then there's something called pyelonephritis, which is an infection of the urinary tract. So the infection can track up urethra, the kidneys, cause more severe symptoms. But urinary tract can then go on to become pyelonephritis. So it's important to have that as another differential, and so when I'll talk about safety netting, but also to tell the patient the signs of that condition. So if things do get worse, what they should do, where they should go to seek help. A sexually transmitted infection that can present in the same way. But like she said, she's got a husband. You can, of course, ask questions, sexual health history, to ask about, is she having unprotected intercourse? Who is she having intercourse with? People are married, but that doesn't mean that they have one sexual partner. So you don't want to cause any offense, but it's something that does have to be asked at times. Medications can cause those symptoms, and of course malignancy, but she's fit and well, and it's something that you have to think about. But if there are no red flags, which again I do talk about in my clinical 5 in 5 videos, I think it makes it a bit less likely. Examination and investigations. So you would want to do an abdominal examination, feel her tummy, below the kidneys. You would want to check her urine with a urine dipstick, and you would want to measure her vital observations. And you would also want to make sure that in those observations, you're definitely checking her temperature, because you want to make sure that she does not have a temperature. If she has a fever, then this is indicating something a bit more serious, something a bit more systemic. So you would want to check that she doesn't have a fever. Now, if we're doing this remotely, you don't really have access to any of this. The patient can take their temperature, of course, they can check their heart rate, they can check their blood pressure, which does give you some information. But and you can also ask the patient to drop in a urine sample at the surgery, and that can be sent off to the lab. But you don't necessarily have to have access to any of this to come up with a diagnosis and a management plan. So diagnosis would be a urinary tract infection. I think that's the most likely cause for her symptoms. And treatments, there are guidelines to help us treat these conditions, but it would be a 3-day course in a female. For a male, it would be a little bit longer. And you would choose an antibiotic that would be based on the guidelines, based on antibiotic resistance, for one. So we would prescribe a particular antibiotic based on, like I said, local guidelines and what is advised. Then you would follow up on safety nets. So you would say to the patient that, complete the 3-day course. However, if you are still having symptoms after you've completed that antibiotic course, then of course let us know, give us a call, come into the surgery for a face-to-face appointment. If she notices that her symptoms get worse during the antibiotic course, then of course she should let us know or someone know. If she had blood in her urine, then she definitely needs to repeat that for us afterwards, because we want to make sure the blood has gone, because one of the causes of blood in the urine is an infection, but there are other causes of blood in the urine, such as malignancy. And so we wouldn't want to overlook this. We wouldn't want to miss this, potentially life-threatening diagnosis. So if she did have blood in her urine on the first, or if she could see blood in her urine, or if she had blood in the urine on the urine test, then we would definitely need to follow her up and check that the blood has resolved, has gone from her urine. And if she has any other concerns, then she should let us know. She should call NHS 111, which is a phone line which patients can call to speak to someone who, like a call handler, who will then essentially triage or sort the patients out based on their conditions and decide whether they need to speak to a clinician, whether they need to go into hospital, whether they need a GP appointment. And that's available 24/7. So you can always say to the patient, if the GP surgery is closed, or if we're open, you can't get through for whatever reason, you can always call NHS 111. And there's also out of hours care, again, which I've spoken about on my YouTube channel, and A&E. If things are really, really bad. So always explain to the patient, when you safety net, what they should be looking out for, the time course roughly of their illness, and where they should go to seek further medical support and advice. Advice for aspiring medics. So I think what you should really ask yourself is, why medicine? And make sure that you have very, very clear reasons as to why you're choosing this demanding, challenging, but yet deeply fulfilling and gratifying career. Why do you want to be a doctor versus another healthcare professional? If you feel that you want to study medicine, you want to be a doctor because you want to help people, there's nothing wrong in saying that. It doesn't matter how cliche that sounds. If that's your reason, then that's perfectly fine. But I would say, do your research. Please look into the career. Please don't be narrow-minded. Think about a number of different specialties. Don't just think, oh, this is what I want to do. I want to be, a cardiac surgeon. That's great if you definitely know you want to do that. But I would say be open-minded, because things change. Like I said here, you will change. Things will happen to you in your life that will change your outlook and your perspective, which will then impact your career. So always be open-minded and just be aware that you will change. Where you are now is not, or how you feel now is not going to be where you are and how you feel in the future. So always just think about what could happen in 5-10 years and how things might change and what you might need to think about. Focus on you and no one else. You will be surrounded by many, very talented and highly ambitious and amazing individuals at medical school, which can make many people feel like they're not doing well enough, they're not doing enough in general. But I would say focus on you, set your own targets, your own goals, compete with yourself, because if you don't, you will quickly become very unhappy. And medical school and, this career, it shouldn't be an unhappy one. So that's the end of my talk. I hope you enjoyed it. I hope you gained valuable information from it. Of course, you can't ask me questions now because it's a recorded talk, but if you do have any questions, I'm more than happy to answer them. So feel free to send them in. And yes, I hope you enjoyed it, and take care.